My name's Joe Scott-Jones. I'm a GP in Apotiki, and I'm here sitting on the couch at the National Rural Health Conference New Zealand 2016 with Roger Strasser from the Northern Ontario School of Medicine. Roger, tell us a little bit about your background.
Well, first, Joe, thank you very much for inviting me to be part of this conference. It's really been fantastic. I'm thoroughly enjoying being here. It's very exciting. My background actually, as you could probably hear, is from Australia. I grew up in Melbourne, and I trained as a rural practitioner and practiced in Gippsland, east of Melbourne. Became involved there with academic side of things, and Monash University in particular, and was involved in establishing the Monash University School of Rural Health. And then in 2002, the opportunity came to move to Canada. By the time I left in 2002, the School of Rural Health at Monash had four main sites and a network of other teaching and research sites spread over quite a large rural area. We provided clinical education for students in medicine, nursing, pharmacy, a range of other health disciplines, and we also we did research. And so the opportunity when it came in 2002 to move to Canada to be involved in establishing a full medical school that was rural-based and multi-site just seemed like the chance of a lifetime. And that's really how it worked out.
Now, I realise I've been totally unfair in asking you this to summarise your life in this very sort of brief moment, because to me you are the foremost rural health guru in rural health research and education in particular, and I won't embarrass you by asking you to acknowledge that role. I think, but I think for most people who just will Google your name and find some of the canon of your research and education work. It's phenomenal for us to have you here and bringing some key messages to the conference. Yesterday you gave a keynote speech. I don't know whether I can challenge you to summarize that in a few minutes as well.
Well, the theme was on what's called socially accountable medical education, and I presented the model of distributed community engaged learning, which we have developed in Northern Ontario. So, as I say, I moved to Northern Ontario in 2002, and we had the official opening of the Northern Ontario School of Medicine in 2005. So we're actually celebrating our 10th anniversary. We developed our model, first of all, guided very much by the communities. So it was the communities of Northern Ontario that said, if we're ever going to have enough doctors, if we're ever going to improve the health of the people of Northern Ontario, we need our own Northern Ontario School of Medicine. And so that gave us that impetus from the community, the social accountability mandate, which was really a focus on improving the health of people of Northern Ontario. And so that's guided the development of our program. Our model, the distributed part, there are over 90 sites across Northern Ontario, which is geographically very large, where our students and our other learners may undertake part of their clinical learning. We rely heavily on electronic communications to connect all of the sites, both in real time and asynchronously. And we have an extensive digital library service, which means that our students and our academic staff, community members, if they have access to the internet, they have access to educational resources, pretty much the same as if they're in a big city, like in a teaching hospital environment. But the real centerpiece of our model is the community engagement, the active participation of communities. We have interdependent partnerships with communities right across Northern Ontario, and the communities play a vital role really in welcoming the students and their families and helping them to feel at home in the community while the students are there. And of course there's a potential future recruitment opportunity for the communities with every student that comes and their families. So that's good. But the communities actually provide more. They really enhance the learning environment and help our students to appreciate the social determinants of health at the local level in the communities.
So is the social accountability agenda, the drive from communities to it's not just about having the health professionals trained there, but also driving the agenda of how they're trained, is my understanding it. Is that?
Absolutely, yeah. So the communities have very much contributed to the development and the delivery of our program. I mean, to give an example, just say the Indigenous people, okay? We have over 100 First Nations, so self-governing communities of First Nation, Aboriginal, Indigenous people. And we, early on, we held a big workshop, over 100 Indigenous people from across Northern Ontario, and asked them for their guidance as to how we should respond to their needs and develop a school. And one of their recommendations was that all of our students should actually have an early experience in their communities. And so that's translated into 4 weeks at the end of first year, where all of our students, they go and they live and they learn in the Indigenous communities. They're in the communities, it's an immersive experience. They're there to learn from the communities about the history, the tradition, the culture, the health issues, social issues as well. So that's an example where the community has very much guided and contributes to the delivery of our program.
Is this a unique in the world, what you're doing? Were you the first? Or?
Yes, so we're certainly the first medical school in the world where all of the students have an immersive experience in Indigenous communities. We're also the first medical school in the world where all of the students have what's called a longitudinal integrated clerkship. So this is the principal clinical year. This is the year when the students make the transition from being classroom learners to clinicians. And rather than spending that year in a teaching hospital and doing, clerkship blocks, they call them, in internal medicine, surgery and pediatrics, our students actually go to one of 15 large rural, small urban communities, and they live in that community for the whole year, and they're actually based in general practice. And they see patients. So in a sense, you could say the curriculum walks through the door, okay? Like the first patient, that might be a child, that's pediatrics, okay? The next patient, pregnant, obstetrics, okay? The next patient has a surgical problem. The learning objectives for that year in internal medicine, surgery, pediatrics, and the 6 core clinical disciplines are just the same as in the other medical schools, but the learning environment is very different. Our students are learning their core clinical medicine from the general practice community perspective. So that's another, we're the only school or the first school in the world actually where all of the students have a long-term integrated clerkship for their principal clinical year.
So that principle in education of having validity of your learning experience relating to the outcome that you're achieving. It just everything aligns, and in terms of the learning experience for the outcome that you're intending, and presumably the assessment as well is sort of all linked in together. It's a fantastic model. Has it been looked at and replicated in other countries?
Oh yes, there are other examples of medical schools, health professional schools like ours in other countries. Some even that predated our school, and others that have been actually follow our model essentially in many different countries, and a mix of developed and developing countries, countries like the Philippines. There's one in the north of Brazil which is really following our model. It's a new school, just started last year. So yes, there's certainly a sense in many different countries that this model we have is particularly relevant where you have large rural areas or even small rural areas, but rural communities that are underserved and in need of healthcare and doctors and other health professionals to provide access to healthcare.
And I know you know the New Zealand system sort of reasonably well. That you've had some conversations during your time in New Zealand this time. Do you have? What's your reflection on where our system is now, and where you think we should go over the next few years, if we were to achieve some of the goals that we're wanting to in terms of addressing our rural workforce issues and getting students into rural communities?
So you have some great strengths here in New Zealand, the rural hospital medicine training and the rural general practice training arrangements. There is some medical students have a rural immersion experience. So I think there's some excellent initiatives that are already in place in New Zealand. I think there's great potential though to do a lot more, and really to put in place a sort of entire pathway. So in Northern Ontario, we actually have the concept of the life cycle of a doctor or a health professional, right, starting even at high school level, or for Indigenous students, primary school level, encouraging in the rural communities to see that they have a future for themselves that might be in healthcare and say in becoming a doctor, so that they're motivated to study and get the grades and get into university medical school and then become doctors or other health professionals. So I think there's room for that, and the way I can see that happening in New Zealand is again with the active community participation, the rural communities really coming together, and in partnership with the health professional organisations and the universities to develop rural-based programs which then has the pathway right through, so that the students who've grown up in the rural communities have the opportunity to do a lot of their clinical learning in that same setting, and then after they graduate, even in their first couple of years postgraduate, clinical work in the rural communities, and then into the training programs.
Yeah.
So a pathway that's laid out, I think that will serve New Zealand very well.
Yeah.
And likely to be successful, as we've had in Northern Ontario, of producing graduates who have the skills and the desire and the commitment to practice where they're most needed in the underserved rural communities.
Yes, yeah. And one of the beauties of this is, of course, that with the system that you have, you produce very well-rounded clinicians who are capable of working in a generalized field, and
yes.
Many will choose general practice, but
yes.
many others will choose other specialties, but
yes.
they'll have a very broad base of experience
yes.
on which to put, because when people turn up in hospital needing their appendix
yes.
removed, then sometimes they've also got a funny rash or a
yes.
thing as well. So
yes.
Thank you so much for your involvement with the conference, Roger, and for all that you're doing. And I know that we can look forward to further support from you and advice as we move forward over the next few years. So thank you.
Well, it's been a great pleasure to be here. I've really enjoyed myself, as I said, and I do want to thank you and the organisers of the conference for inviting me to be here. And I'm certainly keen and willing to stay in touch and to encourage further developments of rural health professional education here in New Zealand.
Yeah, fantastic. Thank you very much.
Okay.